so I'll be the course director for today. And my goal is to teach y'all everything that I've learned throughout the past 15 years and try to get all that information in one day for y'all. It's going to be a lot, it's going to be a full day, but we'll get through. And it's really about you guys. So I really want this to be an opportunity for you guys to come. I'm sure a lot of y'all have questions and are looking for clarifying concepts or trying to figure out better ways to do something. Some of y'all are already doing some of these procedures and trying to see how you can do better with those procedures and so forth. So anyhow, again, just let me know as we go through the day. We'll have plenty of opportunities for doing Q&As, and so we'll just be queuing those as we go through. And so then again, we have a great staff, faculty staff today, and it's this year in particular, I'm really excited because we have 9 alumni from our ASMI program that they're here between the faculty and some of the attendees, and so it's been great to see some of those folks again and catch up. So we'll go ahead and start, and like everything, I strongly believe in laying down a strong foundation of knowledge so then y'all can build upon it, right? And so in the end, orthobiologics, there's a lot of hype, there's a lot of hope, but there's also a lot of information, and I think we got to put all of that together, right? And so in the end, it's about treating our patients the best way possible, but I also believe it's about setting real expectations. And so you have someone who tore their meniscus and they had a meniscectomy. Well, you can't grow that meniscus back, but there's other processes that happen in the joint that will actually get the patient to be pain-free, get their function back. And so we'll be talking about all of that. So anyhow, so let's go ahead and start and go over the objectives for this course. So we're going to be defining So we're going to be defining the various orthobiologic products. In this course in particular, we're going to be focusing on autologous products. That means products that are harvested from the patient's own body. And so we're not going to be covering allograft products like placenta-derived or anything like that. So we're going to be focusing on PRP, bone marrow, and adipose. We're going to review the literature behind it, and then we're also going to go over the different techniques that you can obtain these products. So I like to start off with putting in context, a case. And so this is a very common case that y'all are going to be seeing, especially if you're in the ortho field. Now, you can use PRP also for dermatology. You can use it for other specialties, but for us being, sports medicine ortho, so I'll be talking and focusing a little bit more on ortho and the cases that I'm going to be giving y'all, right? So anyhow, this is a very common case that we see in clinic. So it's a 59-year-old male that comes with chronic tennis elbow for 2 years, and this patient had, just tried everything in the books. Had done 2 rounds of 12 sessions of PT. They've tried everything in the books. Multiple rounds of oral medications, topical medications, multiple rounds of steroid injections, prolotherapy injections with dextrose, and the patient was still not getting a response. They even got rheumatology workup to see if maybe there was some sort of rheumatology issue. And it was all just focal lateral elbow pain. And so we did imaging for this patient, and in this x-ray, so we find 2 things. Let me see if the mouse, no, so the mouse is not moving. Let me just roll this back a little bit. Well, anyhow, I'll talk over here. So there's 2 things that we see in this. This is a lateral epicondyle common extensor tendon coming out. That's the lateral epicondyle here, and the tendon. This is the radial head. There's this hypoechoic area right up in here in the surface, and so that is tendinopathy. And then there's also an interstitial tear down here. And then when you do color flow, there was neovascularization in that area. So this is a very common finding of a chronic tendinopathy. And so we ended up doing a tenotomy and PRP injection for this patient, and I'll show you the outcomes later. But the question here is, why did the patient fail the conservative treatments? I mean, they had done everything in the books for 2 years. And so, historically, we've been talking about treating patients based on pain, right? And so if they're hurting, there's still a problem. If you're pain-free, then in theory you can go back and play sports again. And we would focus on doing anti-inflammatories, icing, bracing, all that kind of stuff. We'd do cortisone shots. But as literature has been coming out, we've actually been seeing that in some of these cases, some of these treatments are actually blocking the healing process of the injury. And we would assume that the patient was cured whenever they would be pain-free, and then we would let them go back to playing tennis, and then they would restrain the area. And so that happens because you would get the pain to go away, but then there would still be some residual damage in that tendon, whether there was the tears or poor collagen deposit or so forth, and then the patient would expect to be 100%, but then restrain that tendon again. So I like this graph because it shows you the process that the tendon goes through to develop tendinopathy. So tendinopathy is not an all or nothing. Even if a patient says, there was this one backhand that I did, and I know when I tore my tendon. And so studies have shown that tendons don't have one single episode where it tears. I went up for a layup and landed. Kobe Bryant did a little push-off, and my Achilles tore. So that tendon had already developed some underlying tendinopathy that was weakening it. And then that one push-off was the straw that broke camel's back. So what I'm making reference to is there was tissue damage that was developing over time, and the tendon was failing to adapt to it and to remodel, but it was still under the pain threshold. And so you would not feel, or maybe it was a little sore, but it would settle down, and then you would get back into it. But then there's that one moment, the aha moment, where then they injure it, and then they stop training, they come in with a lot of pain. So then we would do anti-inflammatories, cortisone shots, we'd get the pain to go away under that pain threshold, but there's still residual tissue damage. And then they would go back and play, and then they would re-injure, and then we'd get stuck here, right? So ultimately, the ideal setting is the patient, when they get back to sports, the tissue has fully healed, right? But you can see that it does take a long time to get there. And so, orthobiologics, what we're trying to achieve is to get this whole process to happen, or this whole process really, they come here and then you get to the healing, this whole process to happen a lot quicker, but also a lot more effective. So there's other factors that can affect the healing. So it's not just that there's residual tissue damage or there's overuse, but there's other things that you need to consider, such as improper biomechanics, potentially systemic comorbidities, and so forth. And so understanding, in ortho, again, so I know that there's some of y'all that are not necessarily in the ortho field, but for those that y'all are, understanding biomechanics is going to be very important. And so a very simple example, if you're getting arthritis in the front of your knees, but they're really tight hamstrings and calf, and they do their jumping like that, they're going to be straining their knees. So you really got to get them biomechanically aligned where they can offload the front part of the knee. Let's say you have someone that has medial knee arthritis from a medial meniscus tear and had a meniscectomy, and now the arthritis is getting worse because they took the meniscus out. and their knee is angina varum, well, you're going to want to get a medial offloader brace to take the pressure off in that area, at least for a certain period, 6 weeks, 3 months, to allow that area to scar down. So, in other words, the and the biomechanics, by the way, that's where working with your colleagues is going to be very important. And so when I talk to my patients, and Dr. Andrews was also very emphatic, what we do in clinic is only 50% of the equation to get them back to 100%. The other 50% comes with addressing all of this, including having a good physical therapist that can work out the biomechanical component, thinking about braces, thinking about systemic comorbidities, and so forth. Now, now we're going to start diving in a little bit more into what's happening with these tendons and joints, and why are they not responding, and so forth. And so this patient came in, so going back to our case, the patient had cortisone shot, they were hurting, so there was this interstitial tear right there, there was this hypoechoic signal here. It's hard to look back, everything in hindsight is 20/20, but it's hard to look back. But there is a chance that this could have been the problem from the get-go, and the patient had 2 cortisone shots, 2 prolotherapy injections. They were not done under ultrasound guidance, they did not get tenotomies, and they were just point of maximal tenderness, drop the needle, tap the bone, inject. So look at where this is, right by the bone. And so I actually wonder if this was an interstitial tear from putting too much steroid into that tendon. Steroids, we do know that it does weaken the tendon. When you look at the studies that show that steroids can lead to an Achilles tendon rupture, so you're going to find that those patients were getting Kenalog injections. Kenalog is the most toxic steroid for your body, and yet it's the most common steroid that y'all have. So first recommendation I'm going to give you, don't have Kenalog. Kenalog is the most toxic steroid. We have Kenalog in our clinic. We'll use it sometimes in joints that they're already bone on bone and the patient is uncontrolled diabetic and they need a steroid for an acute flare-up. But otherwise, you want to try to use another type of steroid, and we'll talk a little bit more about that. Similar problem happens with patients that come in with greater trochanter bursitis, point of maximal tenders. You drop the needle, inject into the area, assuming that you're in the bursa. But if you're not using ultrasound guidance, you may actually be in the gluteus medius tendon, and you can end up tearing that gluteus medius tendon. I have seen those cases. They've been going to rheumatology. They're getting multiple steroid shots every 3 months. They've had 13 shots in 2 years, and now that tendon is torn. So you got to be careful about what you're doing, and you need to understand that pathophysiology so then you can treat it better. So 10 years ago, British Journal of Sports Medicine did a systematic review, and this has still stood the times, and they concluded that cortisone was not the best treatment or the best injection for lateral epicondylitis because it doesn't stimulate the tendon to heal. And the problem with these tendinopathies is not an acute tendinitis, it's really a chronic tendinopathy. So either blood or PRP is going to give you a better outcome than cortisone, and PRP better than blood. And again, we're laying down the foundation of the pathophysiology in this first 30 minutes today. So then we can build upon about how can we get all this tissue to heal with orthobiologics. So this graph shows you a little bit more about what's happening with tendinopathies, what's happening with arthritis. So you got normal tissue that gets injured, whether it's acute or it's chronic. The tissue is going to want to do something about that injury, whether it's appropriate healing or aberrant healing, right? And so with aberrant healing, you end up getting just this collagen deposit that is all kind of a mush in there. It's like a cotton ball. The tendon loses its function, so it doesn't have the tensile strength to withstand the stress of playing sports and so forth. Ideally, we want to get these tissues to get full healing where it replaces the normal function of it. And that's mainly focuses on tendons and ligaments. Well, what about joints? So, what's happening in the joint, and why are these patients having these progressive degenerative changes in osteoarthritis? Well, what's happening is whenever there's some sort of either inflammation or damage, injury to a joint, your body naturally is going to produce these pro-inflammatory mediators because of the acute trauma to it. And we got to remember that everything that's happening in the joint, and almost always, is coming from the joint capsule. It's being regulated by that synovial membrane, that synovium in the joint. So that includes the pro-inflammatory markers that are being poured in when there's an injury, but also the anti-inflammatory markers. They're coming in from the synovial membrane into the joint. And they're the ones that are going to regulate whether that joint goes downhill or whether that joint can actually heal, the trauma, the insult, and get the arthritic process to stop and not get worse. So when I'm treating my patients with arthritis, normally you look at an x-ray and what you're seeing is this, but you're not seeing that. You're not seeing what's happening in the joint capsule. So your physical exam is very important, and I'm always looking to see if the joint feels swollen, to see if there is an effusion, and that's telling me how inflamed is this joint capsule, because the more inflamed it is, the more it's going to be pouring in pro-inflammatory mediators that are going to weaken the cartilage and cause further deterioration, right? Now, if it's advanced arthritis, well, now you've lost all your cartilage, and you're getting into that subchondral bone, and then you're getting that bone edema, subchondral fractures, and so forth, and those get very difficult to treat. And you all know from experience that they frequently end up with knee replacements. But there are ways that you can treat it and get that subchondral bone to heal and hopefully not have to resort to a joint replacement. But take-home message from this slide is, remember that when you're looking at a patient with arthritis, you really want to be thinking about how can I get the synovial membrane to be in the same team with me. And we're working towards trying to get that joint homeostasis, okay? So likewise, BJSM did their systematic review for tendons, OJSM did their systematic, same year, the systematic review for intra-articular steroids for articular cartilage, and what they found was that low doses of steroid can be beneficial, high doses of steroid can be detrimental for a joint. And so you need to be careful, doing like very high doses of steroid. Conventionally, y'all know you don't want to do like multiple steroid shots like every week, every 2 weeks, every 4 weeks, right? You can do a single shot. But if it doesn't get better, you got to be careful about how much more steroid you put in, because steroids have been shown to be chondrotoxic. And so low doses, it's okay. So then we ask ourselves, well, why is a low dose steroid okay but a high dose is bad? So low dose steroid is okay because it is actually getting some of the synovial membrane that is still very inflamed to slow down that production of pro-inflammatory mediators that are weakening the cartilage. But then we got to do something to stimulate the anti-inflammatory mediators to regulate the inflammation of the joint and hopefully get everything to scar down. All right, so that's where orthobiologics come in. How do we stimulate the body to walk away from inflammation and walk towards actual healing, whether it's tendon, ligaments, bone, joints, so forth. So regenerative medicine, it's a little bit of an interchangeable concept with orthobiologics. Basically what we're doing is we're trying to find these biologic products that can help the tissue heal, basically, right? Now, we got to be careful how we define healing, because healing could mean getting inflammation to go away, but it could also mean, growing back tissue. And so when you look at the literature, there's very strong evidence that most orthobiologics can help regulate inflammation, get the inflammation to go away. Depending on the injury, some of them you can get tissue healing, some of them you cannot. And so, for example, you can get an interstitial tear in the tendon to scar down and heal, but you cannot get a rotator cuff tear that ruptured to actually reattach. And when a patient comes in and they're saying, hey, I want to do this PRP because I tore my rotator cuff, you need to educate them, what are you trying to achieve as a physician for them? Now, the patient, you can get that rotator cuff tear to get the inflammation go away, and if it's a partial tear, let's say that's like that, so it may kind of scar down, it may not necessarily grow the tendon cells to reattach, but in many cases, you all know that you can live with a partial rotator cuff tear, and if you're pain-free, then you're fine. I mean, you're not going to be holding back. There's a lot of people that have rotator cuff tears and don't even know about it. So setting expectations is very important. Now, how does orthobiologics work? We're mainly looking at these growth factors, these cells, pericytes, platelet cells, mesenchymal stem cells, or medicinal signaling cells that are basically trying to activate the natural healing response of the body. And they're trying to regulate that process, right? These are the fundamental growth factors that we're trying to get from many of these products, and they all work together with regulating this process. And don't worry about going into the details of this. This is just you can read later on. Benefits of orthobiologics, well, in most cases, if you're doing orthobiologics, you're going to be using autograft products from the patient's own body, so there's minimal risk of complications. There's really no risk of having transmittable diseases because it's not like placenta derived. Orthobiologics have been shown to regulate infectious process. So a lot of wound care clinics are using orthobiologics to get chronic wounds to heal. They're doing two things. One, it actually gets, it helps. So if you think about it, platelet cells, and we'll show you in a minute, platelet cells and white blood cells have very similar specific gravity. So when you take out platelet cells, in many cases, you're also getting a high concentration of leukocytes that will help regulate infectious process. And then you're injecting them into these chronic wounds so it can help get any chronic infection to go away, but then it can also get that tissue to grow and stimulate that healing process, right? And then certainly these procedures are less invasive than doing something like a joint replacement. It's interesting, so this was another study that was published by the British Journal of Sports Medicine, and in their study they found that only 20% of orthopedic surgery procedures are supported by low risk of bias randomized controlled trials, showing that surgery is superior to non-operative treatment. So in other words, there's a lot of things we're doing, in fact most things that we're doing from a surgical standpoint, that have some sort of bias. And basically, we're trying to do what's in the patient's best interest, right? But we also have to be thinking about when we're looking at the literature, where is the literature being published? Who's behind it? What are they trying to achieve? Is there any bias behind their opinion? And that applies also to regenerative medicine literature. So y'all are going to be reading about a lot of articles from orthobiologics, and you also have to put it in context. I always look at what institution did it come out? Who are the authors? And I'll look up the authors' bios, and I'm trying to see, is it someone that could be heavily biased or not? So that's just a word of advice, common word of advice about reading journals. All right, and then just a few more slides, and we're going to go over basic terminology, and then we'll dive deeper into each one of these products. So what is PRP? So PRP, the way I explain it to patient, so your body in your blood has nutrients and growth factors that can stimulate healing. When you cut your skin and bleed, you break a bone and bleed, that tissue can heal very well. But tendons, ligaments, joints don't have good blood flow. So when they're injured, they can get stuck in the hole where they're not getting the nutrients they need to heal. So what we do is we take the patient's own blood, and then we process it and we extract a very high concentration of these growth factors that stimulate healing. And then we're directly injecting them into the tissue under ultrasound guidance to activate that natural healing response in the body. It's most of the literature is behind tendon pathology, but there's a lot of evidence also supporting it for the use of orthobiologics, PRP for osteoarthritis and ligaments. One caveat I always tell patients, it's a potent anti-inflammatory, it can get inflammation to go down, it can stimulate sclerosis and bone scarring down, but it has not been shown to grow enough cartilage where it's clinically relevant. And so we got to be careful when we read some of these articles that they're saying they grew cartilage. Well, they may grow cartilage in the petri dish, but in vivo, it's very hard to grow cartilage. And so don't tell the patient your knee's going to look like a 15-year-old and they're 65 post-meniscectomy. That is not true. All right, so that's PRP, stem cells. So stem cells, this is, you got to be a little careful about how we look at these. So technically, by definition, these are those pluripotent cells that babies have, right? And it's even before a baby's born. I mean, it's like that fetus. It's just these cells that they're just replicating and differentiating into all sorts of different organ cells. Now, your body does have some cells that for many years we've been calling stem cells. Now we're changing the word to medicinal signaling cells, and we'll go that into a minute. But they can actually stimulate tissue to grow and replicate and repair. And we'll go into this, but stem cells, we've been doing research on it for over 100 years. Dr. Kaplan was one of the big proponents of it, and he did a lot of research for the past 50 years. And so we'll go into the history in a few minutes and talk a little bit more about these. Specifically, stem cells in MSK pathology, we're looking at either bone marrow-derived stem cells. Some studies are looking at cartilage-derived stem cells, doing procedures where they'll harvest a piece of cartilage and they'll harvest it and grow more cartilage and then put that plug back into an osteochondral defect. We're looking at fat cells and then some of these stromal cells that support blood formation. Now, what's interesting is, as we mentioned, we haven't really been able to differentiate cells in vivo in real patients where you get let's say a fat cell and make it convert into a cartilage cell. That doesn't happen, and so Tad's going to talk about what does happen when you do, adipose-derived stem cell products and what's really happening there. So there's different ways that you can get these mesenchymal, so specifically, stem cells when they're coming from the body. Bone marrow and adipose are the most common. Now there are some other medicinal signaling cells that you can get from the embryonic cells or the embryonic environment. And again, this course is not going to go over the allograft cells. We'll briefly mention why in a few minutes. So the three most common products that we're going to be talking about is going to be bone marrow aspiration concentrate. And what it is we're taking a sample of patient's bone marrow, and we're processing it, and we're extracting those cells to get a high concentration and then injecting them into the joint. There's a slight variation to doing that bone marrow aspirate concentrate, and it has to do more with the technique of how you aspirate it as opposed to the way that you process it. So one is you aspirate and then you process it. The other one is, so with the regular bone marrow aspiration concentrate, you drop down that needle and you pull out 50 cc's and then you process it in concentrate. But there's another kit, the bone marrow aspiration marrow solutions kit, where it actually has fenestrations in the needle, and you're going to go all the way down, and then you're going to be aspirating for multiple layers, and you get a higher concentration of mesenchymal stem cells. And again, this is bird's eye view. I'm giving you a glimpse of everything we're going to go over. And so as you can see, it's just a lot. There's a lot of information, and I'm sure it's causing a lot of questions and so forth. We're going to answer them, but I wanted to give you a bird's eye view, laying the foundation. Adipose cells, so basically you're just using a needle to aspirate adipose tissue, and then you're processing it to extract those growth factors. One thing to understand about, and Tal will go over it again, is that in the United States, you can only process adipose tissue mechanically. You cannot use any enzymes to break down the product. Now, just briefly mentioning those allograft, coming from the baby, placenta, or umbilical cord, and so forth. So there have been very few studies published showing evidence behind it. The results have been questionable. Most of these studies have been small, level 4 case series. It's interesting, 10 years ago we would have a lot of pharmaceuticals coming and wanting to do research with us on these placenta-derived products. Not a single one of those studies got published. They all eventually shut down. We don't understand, why they wouldn't publish the data, but we suspect that they were not seeing the outcomes, and the pharmaceuticals said, well, we don't want to publish something that makes us look bad. And so the dilemma here is that basically you would harvest these mesenchymal cells from a baby's environment, but it's a donated tissue and you have to process it, even though that I understand placenta can be sterile environment, but you would still have to process it, and that processing was either dehydrating it or freezing it. And so if you think about a fresh salmon and you put it in the freezer for a year, it's never going to taste the same, it's never going to be the same. And so what they found was that many of those cells were actually dying, and they were not surviving that whole processing, anyhow. So these are some of the systematic reviews that were published throughout the years, basically just saying that there's not enough evidence to support the use of it. And because of that, this is the most important thing, FDA does not approve the use of baby-derived or placenta-derived or so forth stem cells in orthopedic procedures. So they're not licensed to be used for that. So, and you got to be real careful. State general attorneys are doing class action lawsuits against certain companies around the nation that were doing this. And I'm sure none of y'all, feel like you look good in orange, right? So you don't want to be in that scenario, right? So Georgia, big class action lawsuit against the stem cell clinic. Kansas, big class action lawsuit against stem cell clinics. So you got to be real careful about what you're doing and how you're marketing it to patients, right? So first, do no harm. Make sure that it's in the patient's best interest. So anyhow, again, this bird's eye view. There's a lot of promising outcomes here with orthobiologics. It's minimally invasive. There's a lot of benefits. And we're going to go over all of this again into more details. And so anyhow, so